I was just going to give a very brief sort of overview of why we need DARE, basically. And it's really just going to very quickly go through some of the challenges as we think about the delivery of healthcare going into the 21st century. And then we're going to get into the specifics of the project. So I guess this is a slide we always like because I'm an obstetrician, and I'll play that again. Over the last few years, we've seen the length of pregnancy has decreased very dramatically at a population level. So these are using data from the perinatal data collection of all births in New South Wales. And you can see that pregnancy duration has shortened. And I guess this is an illustration of what health does really well. We're very good at epidemiology, but we're not good always at explaining why things happen. The other thing we're very good at in health is doing randomized trials. And basically, we often put the results of several randomized trials together and come up with a summary point estimate, which is derived from these clinical trials. And on the basis of this, we're very binary people. We either say something works or it doesn't. In this case, this is the administration of corticosteroids to promote fetal lung maturation. And if we show something works in clinical trials, we apply it to the entire population who are at risk. We're not very thoughtful in terms of individualizing care. And I think as we think about what we've been good at, we need to get better at many things. And to me, this is what people like yourselves and organizations like CSIRO and DARE really bring. We've got access to data, but we use those data really poorly. And we have problems, but in health, we often don't think outside our immediate networks. And I think healthcare of the future really is about bringing all this sort of various expertise in data science and computer science and engineering, really working, with populations and organizations to really deliver healthcare, which is going to be very different. We're a very paternalistic, and I use that term advisedly, in the way we've delivered health in the past. We've been very controlling, and we're moving into a new time. And really, I think this is what we'd like to really strengthen our relationships with organizations such as yours. In terms of data, we've got access to great data at times. So this is New South Wales that basically, as you can see, has over 200 million linked records. These are largely administrative data sets that have been collected for one purpose. So every time someone's admitted to hospital and separate from hospital, there's a record, and these are linked with all sorts of other registries. In our case, we use all the birth records, but we do in New South Wales have great access to these sort of data, but because they're administrative data, there's often a delay in terms of their access. So what we're realizing now is that we've got access to the increasingly electronic medical records that we've got, in our healthcare facilities and at our GPs. And again, there's a wealth of data there. And we're just really trying to start to liberate these data to be able to use them to deliver the sort of healthcare of the future. The other challenge we face here is when we're dealing with health, it's a complex system. And I think we're not very good in health at thinking about, the flow. Here is an example of the flow through North Shore Hospital, but with sort of engineering and sort of some of the newer approaches, I think we can begin to look at health, not just from the individual, but also as a system. And how can we sort of improve healthcare delivery by thinking of it as a complex system, recognizing that what happens in this case in the rehabilitation bed sector is going to affect what happens as you admit patients through emergency. So these are real world problems that the current workforce can't really work with. So I suppose when we sort of engaged first with Sally and hopefully more so with Dare, I think we do need to engage more widely to enable more effective personalization of care. What we tend to traditionally do is the same thing to a large population when we need to do specific things to specific individuals. We need to think about how we're delivering healthcare in terms of what is efficient, what can we afford to do. Increasingly, the data we've used have been sort of administrative and in our electronic medical systems, but we now are on the very cusp of, you know, with people wearing little health devices on their wrists, to be able to use those data, incorporate those so that we can empower individuals to contribute to their own health. And I think in addition to developing new care pathways, you know, we are able to sort of think about how we can use these data to develop new diagnostics, new therapies, and new devices. So I think, you know, we really need to engage with people such as yourselves, because I think you are the answer to some of our problems. And in the past, we've been very reluctant to engage meaningfully. And I suppose that what we're going to hear now is one particular problem and one particular attempt to really personalize care of a condition that is very common in pregnancy. So that's all I was going to say. And I was going to hand over to Tess now, who Tessa is going to talk about the problem we have. And I must apologize, I've got another engagement at 4:30. But
all right. Thank you very much, Jonathan. I'll just share my screen so we can get that up. Started. So can everyone see that?
Yep.
Fantastic. So yeah, thank you, Jonathan, for, I guess, that overview, and Travis as well for providing the opportunity to talk to everyone in DARE, because I think there's a lot of skills that we as clinicians lack that I think will be really useful in helping us with our problems. And I know a lot of you aren't sort of involved with health, so my presentation on gestational diabetes is to provide you all with a bit of a clinical context for the project. So hopefully by the end you can better appreciate the importance of this research. So gestational diabetes is defined as glucose intolerance that's first diagnosed in pregnancy. At present, all pregnant women in Australia have to undergo a glucose tolerance test to be screened for gestational diabetes. And what that involves is being fasted overnight, coming in for a blood test in the morning, having 75 grams of sugar, which is a lot of sugar, followed by another blood test in 1 hour and 2 hours. And if they then go over any of the thresholds as listed here, so greater than 5.1, greater than 10, or greater than 8.5, then they're diagnosed with gestational diabetes. Now, while all women have to go a glucose tolerance test between weeks 24 and 28 to be screened for gestational diabetes, women that are deemed to be at high risk also have to undergo this test earlier in their pregnancy. So some of the risk factors that may lead to this additional test include a history of previous gestational diabetes in a prior pregnancy, a family history of diabetes, a previous large baby, that is a baby greater than 4,500 grams, particular ethnicities such as Pacific Islander, Southeast Asian, Middle Eastern, obesity, which is a BMI greater than 30, or advanced maternal age, in particular those older than 40 years old. So now that we've got a diagnosis of gestational diabetes made, these women are then linked in with an endocrinologist or a diabetes centre where they receive education about what the condition is. And then following this, the management throughout the course of the pregnancy typically involves frequent antenatal hospital visits, which is often up to sort of every 2 weeks, finger prick BSL monitoring, which is generally 4 times a day. Women are provided with dietary plans with a particular focus on carbohydrate content, requiring some women to make quite drastic changes to their diet. Pharmacotherapy can often be required in the form of multiple daily insulin injections, and often these women may need to be delivered early, which increases obstetric intervention, sometimes in the form of induction of labour, instrumental delivery, or caesarean section. Now, all these things, understandably, can significantly increase the anxiety during the course of the pregnancy, both for the woman and her family, not to mention increasing the burden and cost to an already stretched health system. So we're providing quite involved management for these women. So why is it important that we make this diagnosis? In the short term, we know that women with gestational diabetes are at increased risk of developing hypertensive, that's high blood pressure disorders, such as preeclampsia, which can be a life-threatening disorder, as well as polyhydramnios, which can cause a number of pregnancy-related complications, and as mentioned before, increases the risk of a caesarean section being required. For offspring, there are a number of increased short-term adverse events, including preterm birth, higher birth weights, hypoglycemia, which is a low blood sugar reading, respiratory distress, and neonatal intensive care admission. In the long term, both mother and offspring are at high risk of developing type 2 diabetes and obesity, with mothers also at additional risk for cardiovascular disease in later life, and offspring increased risk of neurodevelopmental and neuropsychiatric conditions and ophthalmic disease. So we look at the trends of gestational diabetes over the last 20 years, you'll note that there's been quite a significant increase in the incidence of gestational diabetes, particularly over the last 10 years, with now up to 1 in 6 women being diagnosed with gestational diabetes. Now, there are a number of reasons as to why this might be occurring. We know that more and more people are overweight or obese, which increases insulin resistance and therefore increases the chance of developing diabetes. There are a number of women who are migrating from these ethnic groups that we know are at increased risk of developing diabetes, such as Southeast Asian. And women are having babies later and later in life, with advanced maternal age being known to being a known risk factor for a number of pregnancy complications. But most importantly, the main things we think has really driven this really quite sharp increase is the HARPO study, which I'll be discussing shortly in further detail. So for many years, there was a general lack of consensus for the diagnosis of gestational diabetes, with criteria based around maternal risk for developing type 2 diabetes in later life, or using data from actual non-pregnant populations, and really ignoring sort of short-term adverse risks for women and their offspring with GDM. Prior to the HARPO study, many centres used a two-step approach, which involved a 50-gram glucose challenge, and only if the glucose level was above 7.8 did they then undergo a 2-hour glucose tolerance test. And you'll note that the cutoffs are different to the current approach with the fasting and 2-hour readings. So what was the HARPO study? So the HARPO study, otherwise known as the Hyperglycemia and Adverse Pregnancy Outcome Study, aimed to determine if particular glucose levels, less overt than those used to diagnose type 2 diabetes, led to adverse pregnancy outcomes. It was a 5-year multi-centre, multinational blinded observational study, which included the perinatal outcomes of over 25,000 pregnant women, and analysed these outcomes according to measures of glucose tolerance using the 75-gram 2-hour glucose tolerance test, which is what we use today, between weeks 24 and 32. The primary outcomes included birth weight greater than the 90th percentile, primary caesarean delivery, neonatal hypoglycemia, so low sugar readings, neonatal cord C-peptide levels greater than the 90th percentile, which is often used as a surrogate marker for insulin production of the offspring. So the results of this study found that there was a significant association between the higher maternal glucose levels and higher birth weights and elevated neonatal insulin levels, which likely was a response to the excess glucose passing through the placenta from the mother. And there were weaker but still positive associations seen with some of the other outcomes, including primary caesarean section, and the secondary outcomes of premature birth, shoulder dystocia, birth injury, neonatal intensive care admission, elevated bilirubin levels, and preeclampsia. Unfortunately, they were unable to determine whether higher glucose levels increase the risk of perinatal death due to the inadequate power for this uncommon outcome. So following this landmark trial, in 2010, the International Association of Diabetes and Pregnancy Study Groups convened a consensus panel to summarise the results of HARPO, plus a couple of other studies that were covering a similar area. And the report produced by this panel suggested that routine glucose tolerance tests should be used for all women between 24 and 28 weeks gestation, using a new diagnostic threshold for gestational diabetes based on the adjusted odds ratio of 1.75 times relative to the estimated glucose means from the hypo cohort, particularly looking at birth weight greater than 90th percentile, cord C-peptide, and percent body fat. So if we go back to our sort of graph looking at the trends, and so you can see in here we've got our hypo study in 2008, and then sort of the IAD-PSG guidelines release, and then we have this gradual increase in numbers as the new guidelines and new protocols sort of uptaken throughout Australia. And then on the right, this is a paper published in 2017, which is collating a number of studies showing how the impact of this new diagnostic criteria was having on the numbers of women diagnosed with this condition. Since then, there have been a number of other papers published by the HARPO group using that same cohort of 25,000 women, starting with the original paper in 2008. Following this, there was one in 2009, which looked a bit closer at the increased proportion of babies with neonatal adiposity, which is babies with excess body fat, and higher maternal glucose levels. In 2010, there were another 2 papers published, one reporting on the association of higher maternal BMI and the increased frequency of birth weight greater than the 90th percentile, percent body fat greater than the 90th percentile, cesarean sections and preeclampsia. There are also some weak but non-linear associations with preterm birth and BMI. The second paper delved a little bit more into the association of preeclampsia with maternal BMI and to a lesser extent maternal glucose. 2012 was a bit more of a popular year with 3 papers published looking at alternatives for diagnosis of gestational diabetes, using HbA1c, which is a measure we often use to check the progress of diabetes, but this was found to be inferior. A frequency study was performed which demonstrated what we already knew by this point, that the new diagnostic criteria significantly increases the frequency of diagnosis. But interestingly, it also showed that there was some quite interesting centre-to-centre differences, indicating that perhaps a global diagnostic criteria may not be appropriate for everyone. And then there was a study examining maternal obesity in greater detail, which was supporting the previous paper on maternal BMI and its impact on adverse pregnancy outcomes. And sort of, I think the main thing from this paper really demonstrating that the combined effect of obesity and GDM significantly increased the associations leading to adverse pregnancy outcomes compared to either one alone. And then from 2019 onwards, the HARPO group have now begun publishing follow-up studies trying to determine how maternal glucose levels affect offspring, but I'll not be going into detail of those today. So to summarise, the HARPO study has led to the development of a new international gestational diabetes diagnostic criteria in order to try and minimise some of the significant variation in management for women across the world. Unfortunately, this has led to, this has come at the cost of significantly increasing the number of women diagnosed with this condition and all the related implications, including increased obstetric intervention, maternal anxiety, and cost to the health system. So really, I think that leads us to the final question. As we've significantly increased the burden of this condition, but has it actually improved outcomes? So I'll be handing over to my colleague, Dr. Deborah Randall, to try and answer this question.
Thank you, Tessa. I'll just share my screen. Okay. So just before we get into the ideas grant, I just wanted to quickly run through an analysis that we have just completed looking at trying to answer that question, whether the new diagnostic criteria has actually led to improved outcomes for women with gestational diabetes. So as Tessa mentioned, we have had this change in diagnostic criteria, and it's resulted in increasing numbers of women being diagnosed with gestational diabetes. And I just wanted to point out that because of the change in cutoffs as well, with the fasting level cutoff reduced, there's milder hyperglycemia now being diagnosed. So we feel as though that there's probably a changing description of these women who have gestational diabetes now, with more and more milder cases being diagnosed. So our aims were to try and identify whether the changes have been associated with increased obstetric interventions and or whether they've been associated with improved maternal or neonatal outcomes. Because obviously, as Tessa mentioned, it's been a huge increase in numbers, and also I think it's been estimated to have an increase of about $28 million per year in healthcare costs. So we'd hope to see some pretty significant improvements due to that change. But as Jonathan mentioned, we're very good at doing clinical trials, but unfortunately this change wasn't done with a clinical trial. So it's been adopted gradually in New South Wales, and we haven't actually had clinical trial evidence to say that it's improving outcomes. So we looked at this with the linked population data for New South Wales, and Jonathan was talking about that. We have this wonderful resource where we can link the mother's health records with the baby's health records, and that's done by a third party called the Centre for Health Record Linkage. And they use probabilistic linkage to match those health records based on names and addresses and other information. And for this analysis, we had all of the births in New South Wales from the New South Wales perinatal data collection. And we had hospital data from the New South Wales admitted patient data collection. And we also had deaths data from the New South Wales Register of Births, Deaths and Marriages. And this linkage allows us to get a longitudinal follow-up of the mother and the baby. So we can look at previous hospitalizations and risk factors, as well as antenatal hospital records, the birth records, as well as following up the mothers and babies in the hospitals, and also following up for any deaths as well. So for the population that we used for this study, we had singleton births, which is just the single pregnancies with one baby. So we removed twins and triplets, for example, from our study. We had 10 years of data from January 2006 to 2015, and there was almost 1 million births. We removed some births. We wanted to make sure that all the women in our group had the opportunity to be diagnosed with gestational diabetes and treated with gestational diabetes. And also we removed women who had existing diabetes, as well as some other data issues and non-New South Wales residents. So after the exclusions, we were left with just over 70,000 women with gestational diabetes and just over 800,000 women with no diabetes in our population. We looked at a number of outcomes, and they could be broadly grouped into obstetric interventions and then health outcomes or adverse birth outcomes. So in terms of interventions, we had planned births, which that includes inductions or planned caesarean sections. We had early planned births, so those that are planned before the due date, as well as all caesarean sections. And then we had some indicators of adverse outcomes, such as a composite maternal morbidity indicator, a neonatal morbidity indicator, deaths, large babies, large for gestational age, and neonatal hypoglycemia. So we had some issues with trying to work out how to look at this data, because due to the gradual take-up of the new diagnostic criteria in New South Wales, the group of women who are diagnosed with gestational diabetes is actually changing over time. So we're gradually moving women from the previously undiagnosed group into the diagnosed group. So we couldn't look at just the percentage outcomes among those with gestational diabetes, as we would expect adverse outcomes sort of proportionately to reduce over time as more mild GDM cases were being diagnosed. So instead, we examined predicted scenarios. So we wanted to see what would we expect the outcomes to be if all these newly diagnosed women were similar to the previously diagnosed women. What if they were similar to the previously undiagnosed women? Or what if they were similar to the currently undiagnosed women? And then we compared those scenarios to the actual rates to see what fit the data better. So here's just a diagram of what we might expect to see with incidence of gestational diabetes, having that rapid increase just after the introduction of the change in diagnostic criteria. And so we applied a piecewise Poisson regression on the quarterly incidence data to find a data-driven inflection point. And then we ran an adjusted Poisson model with GDM diagnosis as the outcome and included a parameter for time, linear time, and then an interaction between time and the inflection point. And so we modeled the incidence of gestational diabetes over time, but then predicted the continuation of that trajectory without the inflection point, and then used that prediction to sort of segment the women diagnosed after the inflection point into those we called previous GDM groups, so those who would have been diagnosed anyway if there hadn't been a change in diagnostic criteria, and the additional group, the group that have only been additionally diagnosed since the change in criteria. For those scenarios, we use 3 different models, and we use these models for all of the outcome rates. So for all of the outcomes. So model 1, we predicted the quarterly outcome rate among GDM diagnosed women, assuming that there was no time by inflection point interaction. So that's essentially the adjusted rates with the continuing trajectory before 2011 without the change. Model 2 was an adjusted rate for the non-GDM diagnosed women. So that was an adjusted rate with a continuing trajectory before 2011, again, assuming no change in the diagnostic criteria. And model 3, we looked at the quarterly rate among non-GDM diagnosed women and included the time by inflection point interaction. So this fit the actual non-GDM data across the entire time period. So for all of our scenarios, we applied model 1 to the previous GDM women. So we assumed that all of those women would have the same outcome rates continuing from before 2011. But then we changed the model that we applied to the additional women. So for scenario 1, we assumed that the additional women would have the same adjusted outcome rates as the GDM group before, so that they're essentially clinically the same as the previously diagnosed group. For scenario B, we assumed that this additional group would be clinically the same to the previously undiagnosed group. And for model 3, for scenario 3, we assumed that the additional group would be clinically the same as the currently undiagnosed group. So we had those scenarios and we used bootstrapping to get the confidence intervals around those, and then we compared them to the actual rates. So just going on to the results. This is our actual GDM incidence over time in New South Wales in our population. We've got the data points there in black, and then the modelled, adjusted model in the blue there. So the actual incidence increased from 6% to almost 14% over the time period. And we had that inflection point at the end of 2010, beginning of 2011. And so we used that inflection point to divide the group after that into the previous GDM group and the additional GDM group, and applied those models. Just looking at the change in outcomes over the study period, just in terms of unadjusted rates, we can see that there was quite a few of those outcomes that increased over the time period in the total group. This is not just women with gestational diabetes, this is everyone. So we had increases in interventions, we had increases in morbidity and decreases in perinatal mortality and in macrosomia, which is large babies, and also enlarged for gestational age, but an increase in hypoglycemia over time as well. So here we have the graphs with the predicted scenarios against the actual data. So I'll just explain the graphs here. So we've got the actual outcome rates for women with GDM in the black dots. Then we've also got a smoothed line fit to that as well. That's the dashed line. Then we have scenario A the predicted scenario A in yellow, scenario B in orange, and scenario C in red. So just to remind you, scenario A was when we assumed that the newly diagnosed women had the same rates as the previously diagnosed women. And there are also some confidence limits around those, but they're a bit hard to see. So these are all the intervention rates. And in terms of the intervention rates, we found that they were mostly consistent with scenario A. So the additional GDM group had the same intervention rates as those diagnosed with GDM before the change, even though the makeup we're assuming is the additional women have a milder GDM overall. But when we looked at the morbidity rates, the actual rates of maternal and neonatal morbidity were within the confidence intervals for the 3 different scenarios. And there wasn't much difference between the scenarios there. In terms of the size of the babies, the rates of large babies were closest to scenario A, but that's counterintuitively, the rate of large babies was actually lower for women with GDM than it was for women without GDM. And so in terms of the scenarios, the scenario where we assumed that the rate for the newly diagnosed women is the same as the previously diagnosed women, that was actually a lower rate than if we assumed that the rate would be the same as the non-GDM women. And we think this is because the intervention rates are so much higher, and so women are being birthed earlier and having smaller absolute sort of size babies. In terms of large for gestational age, which takes that gestational age into account, there wasn't much difference between the different scenarios and also the actual rates. For perinatal deaths, overall, they were lower than predicted by any of the scenarios. And for neonatal hypoglycemia, that was lower than predicted by scenario A and closer to scenarios B and C. So in summary, GDM incidence more than doubled over that study period. Planned births and cesarean rates increased. And they were also mostly consistent with the additional GDM group having intervention rates at the same rate as the previous GDM group. Macrosomia rates decreased overall and were consistent with scenario A, and probably due to the earlier intervention for the women with GDM. Neonatal hypoglycemia was lower than scenario A, but actually increased in the total sample over the study period. So even so, that suggests that these women did have a lower risk of having babies with hypoglycemia, but overall this hasn't improved the rates of hypoglycemia over time. Perinatal deaths were lower overall, and they were lower than predicted by all scenarios. So that suggests there's an improvement for all women with GDM, not just the additional cases. So it's difficult to attribute that to the change in criteria. And maternal and neonatal morbidity rates were within the confidence bounds for all the 3 predicted scenarios. So obviously it's a population study. It has limitations. We couldn't measure exact blood glucose levels to determine which women would have actually been diagnosed before and after and compare those. And also there were other factors that changed at the same time. So there were changes in therapeutic targets, with some women being treated more aggressively over the time period that could have influenced the results. But we feel that our study suggests that these new criteria are associated with increased obstetric intervention rates and lower rates of macrosomic babies, but with no clear impacts on maternal or neonatal morbidity. And this is just adding to a growing body of evidence that these new diagnostic criteria are increasing the numbers of women who are diagnosed, but not actually improving outcomes enough to justify the additional burden on women and on the health system. So that's just a link to our published manuscript. So I'll hand over to Sarah now to talk through our Ideas Grant study.
Thanks, Deb. That was great. I'll share my screen with you here. So please let me know that that looks okay. Great. Okay, thank you. So I guess moving on from there, perhaps just taking a step back, because our sugared project, which I'll describe to you now, is really not specifically looking at the diagnostic criteria and whether they're right or wrong, but really, again, drawing back to what Jonathan was saying, how can we do this better? We know gestational diabetes is important and it has relevance, but how can we do it better, and how can we personalize our management better than we're currently doing? So what is sugared? So sugared is the study of gestational diabetes and risk using electronic data, and this is a 5-year NHMRC Ideas Grant that was awarded to our team, and you've met several of the investigators that are on that project, many of whom have spoken already, but those are listed there. And I suppose just to say that the team includes clinicians, so both obstetricians and endocrinologists, also data scientists, we've got biostatisticians, and we're also obviously connecting with you as the mathematicians, and the ability to sort of work with this big data. So in terms of hyperglycemia in pregnancy and what we currently do, so I think you've heard from the team that this is quite burdensome for women. We tell women that they ought to undertake some lifestyle change. A lot of that is to do with what they eat, how they eat, when they eat, so healthy eating and physical activity. And we know even from our own centre here that about 50% of women will need a medication option to help control their blood glucose levels. And I'll point this out to you that, you saw those diagnostic criteria. So you might get diagnosed with the gestational diabetes if your fasting glucose level is 5.1. And then when we then take you into the clinic and treat you, many of the centres will use a target glucose level of 5 fasting. So that's actually, in fact, lower than the diagnostic criteria. So you can already see that if you fall over on that fasting glucose, you've got a pretty high chance that you're going to end up needing a medication choice, because there's not a lot you can do about what your blood sugar level is when you wake up after you've been fasting overnight. So hence there's quite a lot of women who are going to end up on medication choices. And then if we take that decision as, okay, well, a woman's on a medication, then we're going to do something to her, like deliver her baby earlier because of that very fact. We know then we're going to make a significant change across the healthcare system to when women are birthing, which would explain what Jonathan showed as to why there might be one of the reasons why that trend in timing of delivery has changed. So in terms of what it actually means to get gestational diabetes and the obstetric management, for example, the College of Obstetricians says, well, if you've got someone who's well managed and they're on diet control alone, they could go through to full term. That would seem reasonable. Although many centres will then say, well, full term is 40 weeks. We don't want them to birth beyond that. So if it's beyond 40 weeks, well, we'll ask for an induction and not allow a woman to go to 41 or 42 weeks, for example. And then if you're concerned, and of course there's a subjective nature to being concerned, Ranscog says, well, they might need additional ultrasounds. And of course, if you do an additional test, like an ultrasound in pregnancy to find out that the baby maybe looks like they're in the 80th or 90th centile, well, then again, that might lead to some different intervention that you will do as a result of doing that, that investigation. And of course, then if you're particularly concerned, you might choose to induce a woman at 39 weeks or even earlier if, for example, a woman is on medication such as insulin. And even you might order a planned cesarean if the baby is looking big and she's on insulin, for example. So you can see those permutations may really influence what you actually do in terms of timing of delivery. And we actually know that there's quite a lot of variation across New South Wales. So even in our one state, people are doing different things. So for example, in some centres, they think, well, if it's good to diagnose gestational diabetes at 26, 28 weeks, surely it must be good to diagnose them at 12 to 18 weeks, an extrapolation of what the data shows from the Harpo study, for example. And so women are being diagnosed earlier and earlier with this condition of gestational diabetes. And again, those diagnostic criteria are being used in all different ways. In fact, some centres in Australia still are not quite accepting the international standard, again, because of the impact that would have on the burden on the healthcare system. And then the target glucose levels could be different. So I said, for example, in our centre, the target fasting glucose is 5, yet in another centre it might be 5.3. So why would you choose 5.3 and not 5? Again, a lot of that comes down to what the burden on your healthcare system would be if you actually use those tighter targets, which are the ones that are suggested by a lot of the societies and committees. And then there's clinician preference as to what medication you might be recommended if you're pregnant with gestational diabetes. Some centres might say first line would be metformin, and other centres would say absolutely not. We never use metformin. We only use insulin. And then that decision on medication would have impact on what then goes on and what is likely in terms of timing delivery as well. So this gets to what the Sugared project aims really are. So what do we want to do in this NHMRC grant? Well, we really want to solve the problem of how is it best to manage women with hyperglycemia in pregnancy? Can we provide some recommendations that improve the way we do gestational diabetes, both with respect to glycemic management, but also in terms of obstetric intervention and tests that we do? Can we take clinical factors relevant to a woman and apply that together with the glucose levels to come up with better risk predictions on what is likely in terms of adverse outcomes for mother and baby? So in phase 1, we want to really generate the evidence, and I'll walk you through that. In phase 2, we want to translate this evidence into a useful and a meaningful manner for clinicians to apply. And so something like a dashboard where you can see how your centre does versus another centre would be incredibly helpful. And then we want to, in phase 3, evaluate the success of that intervention to see, well, have we actually made a difference in terms of outcomes for mother and baby and the healthcare system at large. So in phase one, generating the evidence. So our aims are really to develop the evidence by benchmarking hospitals on their risk-adjusted rates for early planned birth, particularly because that has such an impact on the healthcare system and potentially on the offspring. And Jonathan Morris's previous work on timing of delivery has really demonstrated that the timing of birth is important for the offspring with respect to risks, both in the short term but also long term. And then we also want to determine which subgroups of women with gestational diabetes we might be able to say, well, they're at lower risk, so we can do something different from, say, a woman who was at higher risk. So again, personalising that risk relationship. And for the latter, this leads us to this, the use of Bayesian probabilistic clustering analysis, which Travis has really been helping us with, Travis and Richard, on this angle of the analysis. So we've been really fortunate to get our hands on the HARPO data set. So this actually, to be honest with you, wasn't part of our initial NHMRC grant, but we sort of stumbled on the idea, wouldn't it be novel and nice to have this data set for it to essentially help us learn what we then might be able to apply to other data sets. And I guess the advantage of the HARPO data set, which is really unique to it, is that there was no treatment interference with the HARPO study. This was a pure observational study at the time where they were not treating gestational diabetes in the way that we're doing now. And all they were treating at that time was really overt diabetes, which is a very different entity. So having that HARPO data set, we're looking at that closely now to see, okay, well, what can we see from that wasn't already published and what has not already been shown? Can we see these subgroups? Can we see some different risk prediction from that? And then if we can find that, can we then apply it to our other data sets? So the other data sets that we're pulling together, and this has been a mighty job by the team. The first is really the Northern Sydney Local Health District and Central Coast Local Health District clinical data. So this, we want to collect the data from 2012 through to 2020 from our electronic medical record. So this is EMR, which is, everything put into this one sort of EMR system. And so the complexity of extraction is a huge task. And we've been going through that with detail and trying to see whether some of the smaller data sets that various people like our endocrinology department keep might again be able to inform some of the more nuances of what is done that might not be captured on that EMR system. For example, dosage of insulin, or metformin, or was used for a certain time and this was added on. These sorts of ideas that could be really helpful in seeing how things pan out. And then at the population level, we really again want to, like Deb was showing with the study that we've recently published, link data sets that are already well established. So these would include the perinatal data collection and the admitted patient data collection and the birth, deaths and marriages. So we want to connect that together and then see whether some of the Bayesian analyses that we've done with HARPO, for example, then can be applied to our data. And so I think we've basically said that there, the Bayesian probabilistic clustering analysis is really what we intend to use. And then we're going to look at really that hospital variation analysis and how we can see how different centres do things and inform what we do going forward with respect to critical things like timing of delivery. So with the methodology for phase one, so we want to specifically ask questions like, if a woman has gestational diabetes based on a 2-hour glucose level, which she could then maybe adjust what she does with diet, how is that different from a woman who's diagnosed on the fasting glucose level? And how far away from normal levels is she with respect to those glucose levels, and how much of the clinical factors that we already know about, for example, family history or her ethnicity, count towards that outcome that we're interested in? And then also in terms of medication choice, for example, metformin and insulin, how is that manifesting with respect to the outcomes of interest, particularly related to timing of delivery? And with that Bayesian clustering, we want to really delve into the glucose levels and the birth outcomes, and really determine what that relationship is like across those different individuals, and then what is common. And certainly what we want to do is be able to, I guess, see the wood from the trees. How can we pick the woman who is going to have more adverse outcomes versus the woman who might get caught up with this gestational diabetes diagnosis when actual fact she was going to be low risk and have very good outcomes, and how can we pick that out better? And I guess that really just lends itself to that personalised risk prediction tool that we've been talking about. With respect to the hospital variation, I think this is really important because, again, you don't want to be a woman in hospital A where you're given a very different treatment and have a very different outcome or timing of delivery versus being the same woman but delivering in hospital B and potentially having quite a different outcome because of essentially the interventions that you're given. So we really want to have a look at that and be able to really inform hospitals on how they do. So there's that transparency around what everybody's doing. So a multi-level modelling will investigate this. We want to see what hospital factors might explain the variation when we take into account the pregnancy risk factors we already know about. And how is that variation in obstetric management really impacting on the maternal and the neonatal outcomes? And then we want to feed this back into a dashboard-like system to inform clinicians and health systems in what they're doing. So in phase 2, going beyond that phase 1 of just collecting that evidence, we're really intending to be able to provide this information at the clinician level with these sort of personalised risk tools, and then they can use that then to discuss timing of delivery with both their colleagues, but also the patients who obviously this affects so much. And then the hospital variation analysis is going to be allow that benchmarking and dashboard system, allowing hospitals really to see how they do in comparison to other New South Wales-based hospitals. And what we're particularly using there is this concept of a stepwise wedge design, where what we're doing in one LHD, for example, is we're doing that personalised tool versus, you know, hospital B just continuing on or with their usual management. And then comparing those hospitals and then adding on in that sort of stepwise design to sort of see how that looks. And we'll do that across 4 different LHDs to really be able to ascertain how the tools actually perform and how that benchmarking is changing what people actually do. And then in phase 3, this will, in fact, it's almost the most important out of all of our project, will be to actually evaluate whether this really is something that sticks, and does this have an impact for women? Is it useful and acceptable? Have we got communication material that we can inform women about what's going on and also alleviate some of the anxiety that's already existing with gestational diabetes? And of course, we don't want to add to anxiety with more information. So I think the way we deliver that is very important. And likewise, at the clinician level, we want to find that this is useful, acceptable, that people adopt this. You know, it's one thing showing something, but to then enable people to apply it and keep and stick with it is another. And we really want to show that this has an impact on New South Wales level data that we will then again collect to see whether this project has really made that difference. So in terms of our where we're up to now, we're really at the first stage, the first phase of collecting all of these data sets, looking at the HARPO data that we have, analysing that, then collecting this information. As I said, it's pretty complex trying to get all of these data sets together. So that's taking quite a bit of time. And then our overall timeline is we're really in step at the moment with that. I'm hoping to stay on track with it with the phases that you can see rolling out over the next 2 to 3 years, with the intention by the end of the time we get to the end of 2024, we will really have made a significant impact in this area of gestational diabetes. So I hope you all have time to stick around for at least 10-15 minutes to ask us questions, because we've done a lot of talking at you, and we'd be certainly happy to take any questions at this point. So back to you, Gilad.